I'm really pleased to be able to bring you a conversation I've just had with Laura Rathbone, who is a wonderful human and a lovely physiotherapist who is currently based near Amsterdam, but used to work in St Thomas's Hospital at the Input Centre, which is a highly collaborative interdisciplinary centre where they deal with highly complex pain syndromes. So she's very well versed in complex or persistent pain syndromes. She also, as well as being a lovely human with an amazing brain, also has been co-hosting Le Pub Scientifique, which I can never pronounce, but which is basically sessions where people go down the pub with a fantastic researcher, clinician, scientist, and have all the conversations you've wanted to have about the information behind the research, but with a glass of something. And those go on in London, and they also now, thanks to Laura and her friend, go on in Amsterdam, and they're often around conferences as well. You can find them, and she'll talk a little bit about that at the end. So she's really highly skilled in managing complex conditions, and I was really glad to be able to talk to her because she's a very interesting follow on Twitter and Facebook, because she, especially on Twitter, she has a great interest in philosophy, and her website is a fantastic resource for other places to go and articles that she's reading at the moment and things to think about. She's got a great blog as well on her website. She's got a lovely kind of holistic, we talk about words, but an embodied sense of how we treat pain. So maybe a lovely global way of thinking about where we should be going with pain. I certainly think this is the conversation that we need to be having more often now. Where do we sit as a therapist in our role in collaborating with our patients to move forward in treating pain? And so, without further ado, I'll let you go forward with this conversation, and hopefully you enjoy. Any comments, any queries, put them underneath this, or get in touch with me on Facebook or Twitter. And I'll put any links to Laura's websites and Le Pub Scientifique and all the rest of the bits and bobs underneath. So hopefully you enjoy. Welcome, Laura Rathbone, and thank you so much for talking to me today. I wanted to talk to you because you're one of my new friends that has a very good brain, and I absolutely love your tweets. Because half the time I'm just like, yeah, and then half the time I actually have to go and read it 3 or 4 times and then read the papers that you're talking about, and it takes me a while. And I actually said to my friend Virginia, who at some point you will meet because she comes to conferences and stuff with me, and she's really into pain science as well, and she teaches with me. You'll have seen her on teaching on the last weekend that I was she was tutoring with me. She said, so is there anyone else I need to be following? And I was like, you need to follow Laura, because you'll take a bit of time. And I got the nod. I go, yes, she's brilliant, because we like that you know lots of stuff that we don't know, which is why I like talking to people, because then we can learn more things. And you are a pain specialist physio, so you worked at King's, didn't you, for a while?
Well, no, I studied at King's, but I actually worked at St Thomas's on their input pain management program, and I was there when it was still under Lance McCracken, who's now obviously moved over to Sweden. But yeah, so I studied my masters at King's College, and that was the Advanced Neuromusculoskeletal Masters. And part of that was we did obviously our pain modules under Mick Thacker, who had a profound influence on the way I think as a physio, but also just on, I think, who I am as a human. He's a really inspiring and generous man, and mentor. So yeah.
Amazing. I'm incredibly jealous. I've only seen him in the flesh once speak, and he is a very good speaker. So to study with him must have been wonderful.
Challenging, because he will call you out.
Really?
Yeah, and that's good. And I think one of the things that he says is, and I think one of the things we all learn on our cohort, is that it's okay to disagree with each other, but yet still love each other. And it's okay to ask questions when someone says something that you think might not be true anymore. And that's the whole point. We're all part of a learning machine, and we're all trying to learn off each other. So
that's absolutely key. I go on about it all the time when I'm teaching, but we don't know everything. And the really depressing last slide of my weekend is as a yeah, sorry for spoiler alert, is everything I've told you is probably going to be wrong in 5 years, but I'll let you know when it is, because
Absolutely.
that's
Yeah.
the point of how we learn and develop. And you know, my minuscule masters, which isn't research, it was just having a go at having a go. I perpetuated lots of horrible nocebos by talking about trigger points and talking about, you know, physical management and that kind of stuff, which we now know to be really unhelpful. But at the time, that was in vogue, and that's what the thought process was. And I always put up a big poster of nocebos and what's the worst nocebo that you found, and get everyone to scroll on it. And mine is, yep, hands up, I perpetuated this, because you have to be able to say, yeah, I got it wrong, I don't know everything, but we're going to have a go at trying to learn more, which is nicely brings me my segue into me trying to learn more. Now, I was having a conversation with a colleague of mine this week, and we were talking about how, because I'd done some mentoring with one of the 60s, and we were talking about the process this person had gone through to think about back pain, and had done a very biomedical assessment, and then done a very biomedical treatment, which you could take in lots of different ways. And I said, you know, when I sat down with this person, having seen all the notes and everything, because I ended up taking a patient, actually what their main issue was, you know, they haven't got a job, they're not happy in their life, blah, blah, blah. And we had a big chat about that. We chatted about moving in a way that feels good, which is a Sandy Hilton quote, and lots of other bits and bobs. And I sat down with the boss going, why do we feel that we can't do that? So when we've got a very biomedical assessment model, we're going to come out with very biomedical answers that we target, when actually there isn't a box on our minimum data set for how is their life, how is everything going on. So I think the concepts and the position that you guys come from, certainly from Input, which has a great reputation in the UK, we know that being a bit more holistic in your model and your thinking is the way forward. And I think I want to ask you about that.
Right, yeah. Well, I mean, first and foremost, I think it's important to remember that Input is a really special, it's a special setup, really. You know, like, we have a lot of time with our patients, with the people that come and stay with us, to work on how they're experiencing pain and how they're managing all the stuff that comes with having pain. And you know, like, it is truly multidisciplinary, but it's also multimodal, right? So as a discipline, we learn each other's disciplines, so that the boundaries between us become very blurred. So we're more multimodal clinicians working within a multidisciplinary system. So, you know, we have the time and we have the space and we have the sort of the freedom to have a very narrative based model. So our assessments are that probably just don't look the way you would do.
What do your assessments look like? Because one of the things that when I'm teaching, I get a lot, because I give people freedom and I say, I'm giving you permission to not get through the NDS in one session. You know,
Yeah.
go. I draw things, and I, you know, all the tools that we normally need for much more of a narrative assessment. So what do your assessments look like?
Well, I guess, I mean, obviously I'm not there anymore, so it's been a couple of years since I was there, but when I was there, and the way I would handle my assessment is, you know, just sit down in a room and say, you know, tell me what's been going on to bring you here, and how are you feeling today, and you know, where can we go from there? Tell me what's important to you. And very, very quickly, you know, the person sat in front of you then realizes that they have the space to say a lot. And now that can either be something that they find very relaxing and very relieving, and the relief of being able to speak can be something very therapeutic in itself. But, you know, for some people, it's also a bit intolerable not having those boundaries. So you have to be really, really flexible in the situation and be like, okay, this person's really struggling to bring their story out, so I need to be a bit more involved in this and ask a few more questions, or maybe we need to go and do something experiential, so that we can actually get a feel as to what happens when they're struggling with pain, and then the story can come out that way. Or, you know, you just sit back and let them go for it, and essentially because we're it's a tertiary service, so you're not really asking, sort of typical physio questions, because a lot of that has already been done. And of course, they're getting consultant referrals to us. So we don't have the same sort of worries and fears that you might have out in primary or secondary care. So we really do just let them tell us their whole story, and try and figure out what their values are. The most important thing for me in those situations, and when I first meet a person, is that I can create an environment in which they feel they can tell me their story, and I can start to get a sense as to who they are as a person, what their values are, and how they react to their world around them and what the world means to them, I guess.
Which is the most valuable thing. And endless evidence is showing us that telling their own story in their own words in a way that they feel able to is the most powerful thing that you can do. And I know certainly lots and lots of physios will reflect on the fact that as soon as they stop trying to fit the boxes, and in our world, it's how many times do you have a wee and how painful is it on a scale of 0 to 10? And when they just ask them, well, when did this start, and how do you feel about that? Tell me about what's been going on. The patient's response is just huge and emotional. They give them hugs and they love them. They bring them cards. They say, thank you so much. No one has ever listened to me like you listened to me for an hour. And I feel like that is the most valuable thing that we can do. But I think I left the NHS because I wasn't allowed to do that. And I was very much audited to be in the brackets and in the boxes. And I didn't feel like it was achieving the best care. It was caring for someone if I was like, right, let's test your pelvic floor. Let's see what your pelvis is like. Let's stand on one leg. It didn't mean as much. And so there's certainly a movement within pelvic health and pelvic pain assessment treatment to move much more towards a holistic model, which is the only way that we can kind of talk about it. But we need better words for it. So
I totally agree. How do you talk about the whole human without the connotation of the word holistic? It sort of makes me. Ugh.
Yeah, holisticism is not something that it's not within our scope of practice. What does that mean? Does that and sometimes my physio colleagues at work, my MSK colleagues, say it's my voodoo, and I go, yeah, I chat with people. but
I think also we have to be really careful what we say to the people that come to see us as well, because if they obviously there's an expectation, and we know that they show more of themselves to certain clinicians than to others, and they will modify and alter their message based upon what they think the receiver is wanting to hear. And so if we start calling ourselves holistic, I think that the connotation of that is we're almost sort of spiritual or alternative, and we're not necessarily wanting to align ourselves with that industry, although there's nothing really wrong with it. It's just that what we're saying is that this is an evidence-based scientific approach to looking at the whole person experience that comes with pain.
So what word have you got for that?
So I tend to try and say things like we're trying to look at a whole person picture, or you can use words like embodied. People are able to sort of figure that out, I think, or realize that we're looking at something more. But I tend to say it's of course, like it's sort of, obviously we've got, say for example, we've got pain in the back, but that back belongs to a person, and I want to know about that person as much as I want to know about your back, and that's what we're trying to get to.
And that is ostensibly why I left the NHS, as much as I absolutely love it. But the moment when I had one day where I was told that an MS sufferer in a wheelchair for the first time was a shoulder, and I was seeing her for a shoulder. And I couldn't get her in the department. I couldn't get her out of the chair because we didn't have a hoist in MSK because it's not neuro set up. I didn't have space for the wheelchair or her husband. Her husband had to climb on the bed and go behind her.
It's not funny at all. I can totally relate to this situation. Yeah,
it's just miserable. So that that people aren't bits of their body. You have to take the whole situation into account, and we know that speeds care, and you can get so much further with someone if you spend the time. We were back in the day when back at uni, we were told listen to your patients and they will tell you how to heal them. and that needs to encompass what's going on with them. The amount of patients that I get with bladder pain syndrome coming in, having a flare and saying, so I talk about bears with my patients as stressors, because it's sometimes a simple idea. And the amount of people that come in and say, you need to help me find my bears, because I can't work out what the bears are, and I just want to talk to you. And I'll go, okay. And the last one that's quite a good example in my mind was someone that I was like, well, have you done the things that normally help you? So have you done the stretches? Have you done the bath? Have you done the releases? Stuff like that. Yeah, that's not changed. My diet's good. Great. Okay, well, what else is going on? How's your other half? Yeah, good. How's your family? Good. You getting exercise? You getting sleep? Yeah, fine. How's work? Oh, I hate my job. Oh, I hate my job. That was literally her realization. Oh, I hate it. And I went, great. Well, what can you do about that? And she literally went away and put in a CV, had a little bit of physical treatment from me because she needed reassurance. Her homework for the week was to put in a CV to a couple of places. She set up a couple of interviews, came back next week, no pain.
Wow, that's a wonderful outcome, isn't it? And I think there's so much, in more under that, isn't there? You've got a person who obviously has stuff going on in their life and has a sort of I don't know, how would we say this? I don't want to say holistic, but it has a kind of has a kind of person response that might mean that pain is part of their experience when they're feeling more stressed out, and or when they're feeling like more vulnerable, or that the world isn't necessarily, they aren't necessarily in balance with their world, whatever that means. Yeah, and I guess that the hard thing, so one of the places where I would come out with someone who has persistent pain is that maybe one of the ways that we might start to work with that is that we don't necessarily always need to get rid of pain when we get it, and it's about how do you have pain, because we recognize that unfortunately this is a part of your experience, and not constantly be trying to get rid of it all the time. Because sometimes that's not helpful. So, and I think that's where acceptance and commitment therapy helps a lot, because it sort of talks about, okay, well, is this a helpful way, is this a helpful behavior or a helpful way of dealing with this, or is this an unhelpful way? Helpful being that it takes you towards your values, and unhelpful being that it takes you away from them. And the constant need to relieve pain when there is pain can sometimes be very helpful, because it means that you seek the appropriate care and the appropriate treatment, and then if your pain responds to those treatments very well, then it can be a very helpful thing. But on the flip side, it can also mean that every time you get pain, you have to go through this whole treatment therapeutic approach, and what if one of those times you can't figure out what is the stressor, or what is the thing that is affecting them, because we all have stuff going on all the time, but it's not necessarily that that's the thing that's causing the pain. So what about then? What do you do then?
Well, have you read Tim Park's Teach Us to Sit Still?
Yeah, I have it on the bookshelf, and I read the first few pages, but I haven't actually got through the whole book yet. So
it's a lovely. We like it because it's he's very anti holicism in the true sense of the original sense of the word. That he thinks it's all no, I'm not going to swear. You know what I mean?
We're all grown-ups.
Yeah, exactly. But he thinks it's nonsense. But then he goes on this journey. So about 100 pages in, it gets a bit better. But there's a lot of trying to. I think he was incredibly empowered to begin with, which is having, it's rare that, not rare, but it's not often that people will come along that feel that empowered. So he didn't want surgery for his prostate pain. He because he was told, he said, well, is it going to make me better? And they said, probably not, but 60% chance you'll still be in pain because it's nothing to do with the prostate, but we'll take your prostate out anyway, and you'll be incontinent and might not be able to get it up and might not be able to feel anything, and you'll still be in pain. Yeah, win-win, hey. So he was empowered enough to not be afraid of what was going on, and say, I don't want that to be the way that I go forward. And so you all right there?
Yeah, sorry. Someone's literally my friend and neighbour has just put stuff through my letterbox. Hang on a minute. Let me just help.
So he was very empowered to begin with, and chose his experience. And he said, well, I've read the research on this, and one part of it is meditation, so I think I'm going to do more of that. And he recognized that a big part of his life was very much traveling internationally, being away from home, quite stressful. And there was a moment where he accepted that actually it wasn't going to get better quickly, and it might not get better. So he was just going to try and make his life a little bit more bearable. At which point he really changed his pain experience. So he was really, really thinking about, from a cognitive point of view, we go through this, we talk about it a lot just because it's quite interesting what the brain's done there, and kind of changing his sensory perception and all sorts of stuff to do with threat. But he changed his own experience, and now he's pain-free as long as he meditates for an hour or two a day, which has become part of his daily life and coping strategies. And as you say, more towards more towards his values. So
I mean, it's really cool that he's been able to do that and take and allot the time towards meditation. And I guess if it is something that has a powerful and profound impact on your pain experience, then you're going to make the time for it, aren't you? It's going to become a huge part of your life. And in a way, the process of change there may well be through this process within ACT, which is this idea of the self as a context, because a part of him has now changed. As opposed to using a technique, there's a whole part of his identity with his pain and his routine with his pain and how he manages his pain, and also like what it means to him has started to shift. And that shift is a very powerful shift.
It's immense. And that's, I think we're on the same page, which is why I find your tweets very interesting, about the approach that we want to be taking to patients. That now I'm not going to ask you to explain completely ACT, because I think a little podcast and a little vlog.
I have my little very professional cheat sheet here.
Amazing. But if you could summarize the headlines that people might want to go and read more about what this kind of approach to persistent pain might look like.
So I've sort of been thinking about this morning, like what would I say ACT was? I guess acceptance and commitment therapy is a psychological framework that we see patients through. So it's to do with not only the person that's sitting in front of you, but also your role within that relationship and setting up that therapeutic alliance. It has pretty strict framework as to what it is. There's the hexaflex, which talks about the processes of change, and then within those processes of change, there's like a kind of tool box of techniques to try and focus on and to use with your patients in order to try to develop and nurture and foster the sort of space within the human to become more psychologically flexible within their lives and the way they experience unhelpful events and suffering really is what we're working with. So I guess it's hard to explain it in a sort of linear way, but the way I think it looks is that you're trying to figure out with a person, okay, how much room is there in how you're managing this for us to have a wriggle about, first of all. So are we able to start doing like behavioral experiments or exposure experiments, whatever you want to call it, to see what's your response in this and what is your strategy for management, so that we can figure out, okay, is that helping you or is it not helping you? Because we don't necessarily want to change stuff that's working or that's helping. So we want to figure out, okay, so is this helpful and is this unhelpful? So I guess that's sort of what a kind of assessment would look like. I would want to see how that person is managing, and in that moment, are they able to think? Are they able to open up to explore different ways, or is it very, very fixed? Do they have a very rigid way of moving about their world? And then I guess you're trying to think, okay, so what might be helpful here? So if they're very, very fused or very, very sort of fixed to a particular management strategy or a thinking process that might not be helpful, that they've identified as not being very helpful, then you might want to start using things like diffusion to try and present moment awareness, to first of all allow them to sort of see that their behavior, like almost like as an observer. Oh, that's what I do. Okay, yeah. So maybe that's not helpful. And if I can see what I do, then maybe there's enough space for me to try something new. And then yeah, so you're trying to sort of dance around all these processes to see whether, essentially what we want to do is create that little bit of room to move around in, and to ask them to try something different or to explore something different. And that without a doubt has to come from a very, very respectful and like modest place, because that's not a small thing we're asking people to do. That is massive, massive. You know, if you're really, I mean, pain is like, it's human shatteringly devastating, isn't it? When you have pain, it's the thing that sort of stops us from being able to live our life. And that's kind of the point of it, I guess, is that if it's trying to stop you from doing something dangerous, or if it's trying to protect you, if we want to use that analogy, then it's quite useful that it stops us in our tracks. So it's no surprise that it's really powerful. So if you're trying to ask somebody to face up to that and then be flexible within it, you know, that needs to come from a really trusting and loving place as a clinician.
And that, incredibly powerful. I want to snapshot all of that and put that as a tweet from Laura. But yeah, and I think from certainly within pelvic health, the way, and I think possibly why we're a bit more receptive to working like this, is that's how we have to do everything. So if someone turns up with a prolapse, you can't just go, you know, from my point of view, I've seen 17 vaginas today. Fine, whip it out, let's have a look. Okay, do your exercises, enough, on your way. Yeah, exactly, tunnel vision. But it's we have to be much more mindful that this is culturally awful, culturally not socially acceptable. It's something that, you know, they have, when generally most people are worried that everything's going to fall out, and it may be laughable to us when you've done it for many, many years or a decade or longer, but it's a realistic concern, and you have to take that step of like you said, that modesty, that humbleness of going, what you're feeling is appropriate, and I'm not going to diminish it by going, yeah, that's absolutely fine, because that's what consultants have done to them. And in pelvic health, we find a lot of the time it's unpicking all of the nocebo language, all of the things that have been told to people, or their beliefs, slowly over time with love and care, is what undoes a lot of the harm. So at the moment, there's definitely a big move amongst the international community of people that do a lot of work online and kind of a lot of promotion work, to kind of start saying, well, loading is okay in the pelvic floor. And this is all the evidence. And we've had lovely data from the international conferences a couple of weeks ago from ICS showing that loading's okay. But if a woman comes into me and she's, I had one this week who's miserable, she's had 6 kids, she's always run loads to help with her mental health, had sudden prolapse symptoms onset just after a constipation episode, and then said, oh, well, I've been to the GP and the GP says I can't ever run again, but I can't do that because I need this to help me. And she was really, really wound up. And we just had to do lots of talking about what prolapses are. And actually, if you are supported, you can do this. But from the point of view of not dismissing it, go, oh, it's fine, yeah, don't worry. But, you know, being with them in that moment. And we talk about being comfortable with vulnerability. So sitting in the space with the patient. And one of the key skills in pelvic health, because we deal with such embarrassing stuff for people, and also quite a lot of traumatic stuff. You know, we have patients that are abused, you know, have huge histories that sometimes they tell us about, big things that have happened to them. But you have to be able to sit calmly in that space with someone and be comfortable enough in yourself to do that. And it is a skill you can learn, but I find a lot of people that come to pelvic health have had pelvic health issues themselves, or big issues themselves. I've had open heart surgery, I've done lots of nearly dying, so I'm quite comfortable to sit in that little that space of, wow, that happened to you. You know, I had a mum yesterday, or the day before, a couple of days ago, who she's given birth, and that's all she's done. But it's a big thing. And, you know, my on my box it says, like, you know, gestational age at delivery, how heavy was it, what kind of delivery was it, did it have any instrumentation, all the stuff we need to know. But my question to her is, how is your delivery? How are you feeling about that? Because you need to sit in that space with someone if you're going to work out where to take them. And I think in physio we're cognitively inflexible.
Oh, that is like a topic that is very close to my heart. I have been working with ACT for most of my career, and the thing that frustrates me the most is that when we are teaching clinicians ACT, we are teaching clinicians how to do ACT to patients. And my perspective is that we need to be teaching clinicians how to be psychologically flexible and model it and feel it and understand the real confrontation that we're asking patients to have with themselves and people who are in pain to have with themselves. And if you haven't got any idea as to what that feels like, then you're not going to be able to be compassionate and sit in that difficult space with people and be human. And there isn't going to be that space, because to you it's just a process that people just do, and it's not. We're asking them to ask really hard questions about their life and their beliefs and what they think is true and what they think is not true. It's very, very difficult and can be traumatic. And we're dealing with people who are who may have had lots of trauma, so our role is to not be part of that problem. So I think we have to teach people, clinicians, to be flexible, to be psychologically flexible, and to experience that before they go anywhere near clients with it.
But that is such a hard thing. And I talked to Paul Hodges about this actually a couple of years ago when I was at WCAP in Washington, because we were kind of chatting about whether it is an innate skill in communication that some people have, or if it's something that's learnt. Because I see a heightened skill level in pelvic health versus MS, because I sit between the two a lot, and I have done throughout my career. Pelvic health is MSK in a cave with your eyes closed and one finger, and as Sandy will say, but yeah, exactly. But it's that skill level in discussing a sexual practice that someone wants to get back to that you may not be aware of. My classic clinical reasoning of when I finally, as a baby physio, got around to asking someone the mechanism by which they injured themselves after they'd alluded to a sexual act, and it would have been massively shocking. I've been told everything now, so it's not, but it's something I wouldn't take part in. But it's that moment of going, well, okay, well, this turns this person on, and this is what I need to be able to help them to rehab to. So how do you do that? And so within pelvic health, because we're constantly having our biases and our beliefs challenged, I think there is a certain heightened communication standard. We may walk away from those sessions not being like, whoa, but the way when we're with patients, I've seen a real heightened level of skill and empathy, but not a sympathy, which is key with patients. And how do we can teach people ACT, but it's about getting the whole physio population to be much more flexible in their approach, that an ankle may not be an ankle, it might be about their dead grandma and their whatever belief.
Well, that's part of a really big question, I guess. But I think I think you're absolutely right. When people are working within pelvic health, the very context of pelvic, it even within non-pelvic health practitioners, we're already very sort of protective of our own pelvises. So we're going to be more protective of somebody else's pelvis, right? So we're going to be more gentle with somebody else's pelvis, because we think, well, actually that bit's a little bit sensitive for me too. And not necessarily from a pain perspective, but it's a very intimate place, and we perhaps, because we have a very strong feeling about how much we want someone fiddling around in that area, we're more likely to empathize with that in other people. It is hard maybe to have that same feeling about a shoulder.
Yeah,
but
ask people just work on stretching it.
But, the clinical the therapeutic
yeah.
But the reality is that if somebody's shoulder is in pain, it is as important to them, and as vulnerable and as intimate as a pelvis, or a parts of your pelvis, because people don't necessarily want you just like lunging straight in and having to poke around and having to feel around. You do have to pay respect to the fact that represents something that is, painful to someone, and that in itself means that it is more intimate, and they're going to be more protective, and we need to be more respectful of that, because it's
Yeah,
not just a shoulder.
because they, my husband currently has a broken rib, and it is doing his head in, and when someone's in pain, they may not even let their loved ones touch the area that's in pain, yet we as the physio then go, right, I'm going to come straight to that area. You need to, when I teach, we talk about working sub-threat. So you work away from the area towards the area if you need to, and you don't often need to go towards the area. But being mindful of this is not a holy, because I'm not religious, but you know what I mean, a very sacred, that's what I mean, sacred space for people wherever they're in pain. And what we do is, and the way we talk to people before what we do to them is really important. It's like with chaperoning. So it's one of the things I always think about chaperones is that, so obviously in pelvic health we always ask for chaperones, but the point is that you go through a chaperoning process and you talk to the patient. This is what I'm going to do to you. This is what it should feel like. Physio is not going to hurt. If at any time you're uncomfortable, we stop. You do all of this kind of stuff. So then when you say, would you like a chaperone with, are you happy with it just being me and you in here? Would you like another person as a supporter, or would you like someone to observe? In however many years I've been doing it, I've only had a chaperone once, and that was when I was like, you're a bit dodgy, but I've got to assess you. When I wanted a chaperone, because I think if you get there and you haven't talked to someone and you haven't made that connection, and they're saying, I don't want you touching me without someone else checking what you're doing is right, you haven't done your job right, and you shouldn't be assessing them if they don't feel comfortable to have it unchaperoned.
Well, I mean, I think, I don't know. That's a difficult one, because I mean, it doesn't often come up in my area, and I'm just thinking about that now and about what that means. I don't know whether that's
a yes, you can touch me statement, I think.
Yeah.
And I think in MSK it's a difficult, I mean, they come in expecting it, I think, to some degree, because they expect the physio to make them bend over. And I had a lady in this week with back pain and groin pain, and she wanted to see a female because she was expecting to take her trousers off, even though I didn't take her trousers off, because it was back pain. And so the expectation there is that you are going to make me move and touch me. And having that consent to do that, a huge amount of relationship building needs to go on before you go anywhere near touching someone. And you might not, unless it's people, you don't have to touch them for weeks and weeks, if not months.
I think that's a really important message, Jilly. Like, I think as physios, we feel like the most important part of our assessment is touching people or getting them to do something or to move in some way. And when this is one of the things, and when you asked about what our assessments might have looked like, or how I might assess someone, I don't necessarily think that I have to get their objective, whatever that means, assessment data on the first session. It might never really be part of how I assess. It might be that I'm just watching them as we move about the room, or as we move towards a value, which might be whatever, looking at how, okay, where do they seem to be struggling? What are they avoiding? What are they backing off from? Where, as opposed to like, oh, can you lift your shoulder up? Well, I mean, who really cares if, I don't really know what that means anymore personally, but
and that's really validating to hear, because a lot of people struggle with the whole, I have to objectively assess, I have to touch this person. But in chronic pain, or persistent pain, sorry, it's not necessarily a useful thing to do.
I just think pain in general, like, I really don't particularly like the temporal diagnosis of persistent pain. I get why we have it, like, of course, like, we tend to expect that a pain experience that is associated with a mechanism of injury is going to subside as their healing takes place, and that would be a sort of predictable, successful relationship with our pain system. There is not a pain system, but our pain experience, you know, and however we choose to define that. But like, and so the idea is that after those 3 months, they become persistent because, but it's just time. It's just really time. I mean, you know, one of the things we know now is that some of the processes that we, you know, like central sensitization and peripheral sensitization are happening very, very early on, way before 3 months. And they happen in people who have a very, you know, effective relationship with their experience of pain and healing as well. So I'm just not really sure why we need to make this definition anymore, why we need to make this differentiation, other than for coding purposes, perhaps. But to the actual person that's sat in front of you, it's just pain.
And that's a really lovely thing to hear. I think a lot of people would be heartened by that. This is a slightly feral one. Come for a loving. So where was I? Yeah. So, and I think I really like your approach because it's a bit more of a humanist approach, but not the psychologically humanist. You know what I mean? You treat the human in front of you, and I've always felt like that's an important step to take. So what is your first thought when you look at someone in pain and you are there as their physio to treat them? What's the first thought that you have going into an assessment?
Oh gosh, that is a really good question. I'm going to steal that question from you and ask other people.
Yeah.
What do I think when I first see a person? I guess I think, okay, how do I, you know, get rid of me as much as possible in this situation so that I can just like sit there and receive them?
Perfect.
Because this is not about me in any way. So, you know, I have an exercise that I do with people when I'm teaching or mentoring or whatever, or developing a clinical group. You know, look at me, what do you see? And I do this with patients as well. And, you know, I'll stand there at the front of the room and I will say, tell me what my privileges are. When you see me, what do you see? What do I represent to you? And, you know, I've done this so many times, and I'll go in straight away with a white jacket on, stethoscope around my neck, you know, clipboard, all that stuff.
Yeah.
And what do you see? You know, what is it that I represent to you? And it's only through really knowing what we bring into the clinical environment are we able to then be like, okay, so I know where I'm coming from, and now I can start to get an understanding as to what the distance is between me and the patient, and how do I quieten down some of the things that maybe I represent to that other person in front of me, so that that person can fill up the whole room, the whole clinical space, because this is all about them.
And that is just wonderful. I love that. And I think that's the key part that we need to be taking from a physio perspective is, you know, yes, we've got outcome measures, we've got paperwork we've got to do, we've got minimum data sets, we're audited, blah, blah, blah. But at the end of the day, if you can make the experience for the patient all about them, and you are, you know, making them feel like you are there standing alongside them in their journey of pain. You are not there as a healer, you are standing alongside them. Setting those expectations up is really important, and it's difficult. And it's certainly difficult if you've got any kind of profile. Hello. So there was another physio I'm aware of, one of my mentors a long time ago, who she used to say that patients would start getting better to her on the train on the way there, because she had such a big high profile. The expectation was massive that she was going to heal them. And by the time they got there, that lots of people improved. Which is a really good insight to have, and I think we should all have that it's you know, most of what we do, and I say this a lot, most of what we do, 80% of healing is conversation and giving somebody love. And I say that generously as someone that's died a lot. I find it's really important that you, as a human, for the allotted time that you have with that person, that you share of yourself, not your experiences, beliefs, or the rest of it, but as human to human, you share of yourself some love and some care. And you can't get your patients better unless you're loving them better a little bit. And that means exactly what you just said, removing your own ego from the room and saying, right, how can I support you to make your steps forward?
Yeah, and again, this is another point where I think, like, you know, having a good working understanding and a sort of like a lived knowledge of what it is to be, you know, using a model like acceptance and commitment therapy can be really helpful here, because, you know, it is all about moving towards the values of the patient, moving, or the person that you're working with. You know, it's not about, well, you know, I've read an article that says that, you know, I don't know, 10 squats 3 times a day is going to help your knee pain, you know, because that means nothing to the person in front of you. It's about, okay, well, what are the things that you really love to do? Okay, that is the goal. That is the goal. And, you know, how do I get your lived experience of pain that may be in a particular part of your body? How do I get that part of your body and yourself and your human to be able to do more of what you want to do? And that might look very traditional. It might look like very traditional physio methods, but yeah, it's how you're coming at it, it's how you're coming about it, and the way you're talking to your patients, and the story of what you're saying. You know, yeah, why are we doing this? Why is it that we are now stood at the top of the staircase to, you know, Waterloo Tube Station or whatever, you know, because, you know, why are we doing that? Because you want to be able to travel around, and the pain in your knee when you go up and down stairs is the problem, right? Well, we've been building our way up to here. Now we need to put the steps in. How do we help yourself, your lived experience of pain? You know, how do we create room within that so that you can do this?
Yeah. Brilliant, absolutely wonderful. If people were wanting to take their first steps into reading and learning about ACT, where would you point them to?
Okay, yeah, so there are a couple of books. There is The Happiness Trap, which is oh gosh, you know, is kind of like the book that everybody gives out to patients that they're working with. It's like that kind of recommendation. It doesn't work for me as a clinician, that book. You know, it's a really nice story, and it's a really nice active book. It's got activities within there. But I don't know whether it's just the way I think. Like, I would rather have a more clinically based book. So there is also ACT Made Simple, which is like the kind of clinician handbook of how to use ACT. So I would say that's quite a good reference. I still use ACT Made Simple all the time, just to go over like exercises and to sort of remind myself, okay, is this really the process that I'm trying to target, and do I really do that? But, you know, the thing that I would say about acceptance and commitment therapy is it's just one approach, but it is a psychological framework approach. So like, it's not something you just learn in 2 days and then off you go acting people better, you know. Like, it's to me like,
skill, yeah, that you need to build.
It's also, I think that it requires like mentoring, and I think it requires experience, and, you know, like pretty hardcore reflection. So, you know, it's a bit like something like motivational interviewing. It's a way that we are with people as opposed to just what we do. So I think it's really important to find a mentor, someone who can sort of coach you through it. So the 2-day course is a great way to get comfortable with the processes and understand the language and what we're trying to achieve. But then you need to find someone to guide you through the process and to help you develop your style, because I think it's a person-centered approach. So you're going to have your own style. The way I do it would be very different to, you know, the way other people do it.
And I think it's a generally an incredibly important thing in life to have lots of mentors and be open to that constant reflection, which unfortunately in pelvic health, because we tend to be one person in a department behind a door, hiding in the corner in a room, finding that mentorship. Yeah, with one finger. You only need this one finger to work. But I'm trying to change that. So all of my bladder heroes are working on #getting out their rooms, so that they are in the gym with patients and doing other stuff that doesn't involve their finger and a vagina all the time, or a penis. And I know
sounds interesting.
Yeah, not necessarily in the penis. But yeah, getting out their room, being a bit more thoughtful about the body attached to the bit of meat that they're treating.
Oh yeah.
And not just being in the room.
This is the thing, isn't it? It's access to good quality information. It's access to you know, compassionate, caring mentoring. You know, there's loads and loads of motivation there to make something that will help people and help people do their jobs, right? But it's just that at the moment that energy is being plowed into something that, may not actually be something that stands up that isn't something that stands up in the evidence. And so we just need to redirect that energy towards something else. So it's finding a gentle way of redirecting it, but also stating the boundary, which is, okay, there actually might not be enough evidence to support that, and actually what is not your fault, but what's happening is there's a bit of confirmational bias there in what you're reading. So one of the things I would always like, not that I know how to do this any better than anyone else, but I'm always like, okay, you've come up, so go and find me some papers that support your thoughts. Now go and find me the exact same amount of papers that don't support your thoughts, and tell me what you think. And then we'll talk about that.
That's a really, really, really lovely way of doing it. I'm going to steal that from her. Thank you. Yeah, and I this is why I do these talks, because I get loads out of it. So thank you for an hour's amazing mentoring chat from you. It's
right. I'm just avoiding baking a birthday cake. That's all.
Oh yeah, no, I can't keep you from your birthday cake. It's nearly kids out of school time.
I've got ages, don't worry about it. But I mean, the caveat on all of that, and this is the hard thing about being a clinician now, and putting your name against a type of approach, which is something that I feel really uncomfortable, though it has just naturally happened that people come to me about acceptance, and I understand that. But I can't remember whose tweet it was that I was commenting on. I think, but I was saying, what am I going to be saying in 5 years about psychological flexibility? I would love to think, it'll be exactly the same because this is the thing, but we don't have the evidence that shows us that is going to withstand that time, because it's not that strong at the moment.
I have some for you. So Jason Kirch in the MAP Research Network has a lovely bit on cognitive flexibility is a predictor of improvement. So patients that have less cognitive flexibility in urological pelvic pain, so bladder pain syndrome, have less, it strongly predicts their lack of improvement. But if they have cognitive flexibility, and if you improve that, then they are strongly predicted with improving in their pain state.
And the main question I have from that is, how are they measuring psychological flexibility?
Because not psychological, cognitive. So they do. He's Mr. Brain Scan Man. So I don't know what they do, but I did chat to him in Washington, and they've got lovely pictures, which work with me. When I did ask him about it, but they've got lots and lots and lots of connections, and then loads of connections.
Yeah.
So
yeah. I think there's something in psychological flexibility and cognitive, being able to be flexible within your reactions to your environment and how you choose to move through your environment and your life. I think there's definitely something interesting there. My whole, I don't have an issue with acceptance and commitment therapy because I think it's a very useful tool, but the most under researched area is the process of context of self, because it's very difficult to measure it. It's so mixed up in meaning, and then how much of ourselves do we really show, and do we show different parts of ourselves at different times? And I always think of it a bit like a Rubik's Cube. In one moment you're seeing this side of the Rubik's Cube, and then in another one you're seeing this side of the Rubik's, and it's like self is a bit like this. How do we really understand what self is? And I think that when acceptance and commitment therapy, when we see nice outcomes for it, that withstand time, which I think is the limitation that we have with most of our therapeutic interventions, that withstand time, because sometimes it does. I think we're probably shifting something within that context, that self as a who am I with this pain. But often what we're seeing is shifts within the process of like, well, I'm able to diffuse in this moment from this thing, or I'm able to use a diffusion technique which helps me to reduce my suffering or the impact of my pain, but not necessarily the pain. And I think that's the interesting bit, and that's maybe the limitation. And maybe in 5 years we're going to be like, yeah, okay, that was a great place to start, hello puss.
Yeah,
exactly. But now we're thinking something else, and maybe who knows what we're thinking. And I think our job is to be flexible with that, and to be like, yeah, my ego is not attached to this therapeutic approach. The only thing my ego is attached to is my life, which is not just physio. It's the who I am in the world. And, you know, this is a therapeutic approach I think is very useful at the moment. I think we're doing something more than just, you know, is somebody able to use mindfulness? Is somebody able to identify their values? Is somebody able to, you know, accept that pain is a part of their present moment experience? You know, although these are massive things to be able to do, so that is a therapeutic just, right?
Yeah.
But I think we might be really shifting something within the human and within their role and place within society that I can't fully explain or understand at the moment. But I think there's something within embodied cognition going on here, and definitely like looking forward to seeing what Mick's going to talk about with predictive processing. I think, you know, in terms of psychological flexibility, are we just opening out that person's experience of novelty, which in itself is starting to change their priors, which may be changing their experience of the world? Yeah, that potentially is what I think we might be doing.
Violating their expectations and showing them new options. I agree. So the from my little bit of research, which, you know, masters, PhDs coming, but with the reduction in simple score, reduction in bother and symptoms of bladder pain when you touch the pelvic floor. We did some treatments for the pelvic floor, and you see a lovely reduction in symptoms. And I talked about it in lots of different ways. But what I think now, how I've talked about it completely has changed over the last 5 years. And now what I think we're doing when we touch someone's pelvic floor repeatedly over time, and all the evidence looks at the act and the outcome as within this horrible measure. But I think I know definitely the way I teach what I think I have achieved is in that, and what I've looked at is that we are absolutely getting that person to engage that area and desensitizing themselves to that area, because we know that the scores are better in people that self-treat as well, alongside, we know, self-efficacy is massive, and it's so much more of a driver for, again, a predictor of outcomes. But that we are absolutely changing that concept of who they are, that pain identity. Because in bladder pain syndrome, interstitial cysts, in chronic conditions, there is an identity that becomes accepted. Whether it's resisted, there is always an identity there. And when we start to, and certainly everything within the media backs that up. And that's why I'm trying to put loads out there that kind of maybe challenges people a little bit to go, oh, there are other options. But when you start to touch someone in that area and you have built this relationship, and then they start to touch that and they believe that they can touch it without it being painful, you get a shift in their belief about themselves and what they think was real. You know, as Sandy says, violating expectations, but doing it gently. Violating is a big word, and that is what I think we're achieving. And it's much more complex and beautiful than just, we're going to stretch the tissues, we're going to improve the blood flow. I think it's much more cognitive than physical, if that makes sense.
Yeah, I mean, I would say it's more embodied. We're really doing something with how that person is, you know, moving as an embodied and embedded agent within their environment, you know. But yeah, I think that's what we're doing. And yeah, if you think of yourself as a human, as a person, so I am a Laura that is constantly moving through time and, you know, updating who I am based upon every moment to moment interactions within my self, body, world, you know, coupling. So every minute, every experience I have is updating this self all the time. And if you're constantly updating in a certain way all the time, if you're living in a certain way all the time, then that is going to become more and more you're going to become more and more precise at experiencing those that type of world, right? And I guess what we're trying to do is say, yeah, you know, that's sort of like what you've been experiencing, but on a cognitive level, you want to do something else. You've come to a place now where you want to try to do other things, or that's not working for you anymore. You don't feel, you know, attuned to your environment anymore. You want to do something different. So what we're going to do is we're going to start creating some instability, some, you know, less precise experiences, some novelty. We're going to start building some novelty into these experiences, into your person, body, world experience. And then maybe we can start changing how precise that prediction is, so that we can start opening out into something else and then become more precise at something else. Because essentially we want to create attunement and precision towards a person, body, world experience that is helpful for that person, that is within their values. I guess the problem is we just don't really know if we can do that. And we don't really know if that is a thing. We don't know if it exists. It's all theoretical, and it's really beautiful, and it's very charming and very like, you just sort of fall down the hole, don't you? Fall down the predictive hole. You're like,
totally. That's the little tiny bit that I'm interested in, with a couple of Canadians and Americans, Katie Kelly being one of them. That how do we create these novel experiences, but using sensory processing? So using sound, using smell, using graded motor imagery for the pelvis, using lots of other things.
Absolutely.
That's probably where the PhD would be. But
I mean, smell is incredibly powerful. We used to do some sessions that, like, I just have to say that the input team that I worked with were some of the most talented clinicians I've ever seen in my life. Like, the way they take human-centered care and human-centered approaches to really dig down into the person in front of you, and they're so brave in the exposure techniques that they have, because they really take people up to that point without flooding, without overwhelming the person. And that's what we're dealing with. It's all fancy way of saying exposure, right? It's a fancy way of talking about graded exposure. But like, it's the way that they do things. We used to do this session, and it wasn't my idea, although I wish it was, because it's brilliant, but it wasn't my idea. It was Warren Travers, who's a great physiotherapist, but nobody will know him, nobody will have heard of him. He does not have a profile. He's just a brilliant physio that is just working in the trenches. And he wanted to do this session where we would bring in different smells, because olfactory, this idea that smell and memory is very connected and that it's very powerful. So we wanted to bring in the smells to see what would happen. And it was really interesting, because we had them all in like little photo, the old Kodak roll boxes. We had all these different things, like coffee beans all crunched up, and I'm trying to think, cigarette butts and like stuff like that. Just all this stuff that maybe we wouldn't think of as a nice thought, but will bring up something, because you can't, with acceptance and commitment therapy, you want to bring stuff up, so that even if it's really powerful, or even if it's not necessarily what you were planning on or aiming for, it's all a therapeutic moment, and everything can be used, every moment can be used for therapy. So you want to bring it up some content. So like, we had all these smells and we were passing them all around, and we were both just like, the first time we did it, blown away by how powerful this session was. Like, it was so emotional. It was so much good work being done by the people who were in there, so much like really brave and emotional places within their history that they were all of a sudden being exposed to and working through. And so I would say, the only thing I would say about smell is that it can be way more powerful than you expect it to be.
Cool.
It was a really good question.
The limited stuff that we've done with smell is all about playing with poopery, again, toilet humour, but trying to see if we can change the experience of defecation or voiding to be a non-painful experience, or a different experience. If they can cognitively put an idea or concept of while using the smell in a safe space, that voiding or dysfunction is not necessarily a threatening or a scary thing, or going to be painful. Playing with expectation, which we will go on at length about another time. But
that's really interesting.
And then spraying in the toilet. I've had one person in the last 2 years who with meditation and poopery, meditation while poopery smell, she was then able to transfer her experience to the toilet and have a pain-free void, which hadn't happened for like 8 years. It doesn't happen consistently, but now she takes it everywhere with her. When she uses the toilet, sprays it, has a wee. And
then the great thing would be able to start recalling that experience without necessarily needing the tool, and then maybe to not even need the experience at all, like, because that's also something, you know, that with these sorts of things, like, where is the end of the therapy? Like, this is why it's such bullshit to ask physios to do 3 to 6 sessions. Oh, what on earth? Why are we letting clinical governance take over our, like, and targets, and private companies take over our autonomy and decision making? It is utter, like, I feel really angry when I think about juniors coming out now and thinking that this is just what physio is, because it's not. You don't have to do that. You are allowed to go against the model if you've got enough evidence and you can support the way you work. And like, you know, how can, you know,
well, I had to leave the NHS to achieve. That's the difficulty. Is I bloody love the NHS. I'm still embedded with my local clinicians. I still help them out as much as I can. But it's I had to leave the NHS to be able to achieve what I think we both agree on is a bit more of a better therapeutic experience for patients and doing our job properly. But you know, we'll hope it gets there. Anyway, you've got loads of resources on your website. I love your literature list. I've got one paper and I'm going to be going through bit by bit.
I'm still updating that. So, I mean, that just came about because I was like, people keep asking me, what have you read about this? Have you read something on this? And I just thought, well, you know what, why not just put that all out there? And then, because I know that I'm always thinking, oh, you know, I'm really interested in illusion, for example, what can I find out about illusion? And I'm always asking, like, other clinicians, what are you reading? So, wow, this just isn't.
Do you want to chat a little bit about Le Pub before?
Oh, that was lovely. Thank you very much. Le Pub Scientifique is a regular discussion group that was started in London, and Tim and Steph have taken it on to be this incredible network and learning environment. And, you know, it's all based on the original ideas. Where, you know, I think it is Pat Wall who originally said, you know, if you're going to talk about work outside of work, then you need to have a drink in your hand. And that's how they came up with it. And so that's the idea. So you meet someone who's interested in the field of pain or studying pain or doing something interesting, and they explain it to you, and you get to ask them questions and talk to them about it, and also share a beer, and, you know, just not take science so seriously. Our jobs are so serious and really heavy. You know, some of the clinic lists that people are working with are really, really heavy lists to be working on. So, you know, quite frankly, most of us need a drink after clinic. And so it's a really nice, friendly environment to, like, explore the big changes that are happening around the science of pain and the delivery of clinical care, you know, in a really nice, informal, non-threatening environment. So you can ask the questions that you might not necessarily want to ask in a big conference. And so we keep it small so that discussion stays lively. So I went to the ones in London, and then, you know, as I came over to Amsterdam, I was like, I need some friends. Tim, please can we do Le Pub in London? And me and my colleague Bart, my friend Bart, who was like my first Dutch friend, who is a really, really cool clinician. So he is one of the NOI teachers and teaches Explain Pain and translated Explain Pain into Dutch so that it was available for Dutch clinicians. So he's a really, really cool guy. And when I moved over to Holland, I sort of emailed him and said, hey, you like pain, I like pain, I'm a clinician, we should be friends. And so we got together and we started organising the pub Scientifique. So we've been doing it for about 2 years now, and we have had some incredible people join us. And next month we have Jared Hall, who is coming from Texas. So we're just so lucky that he's in Amsterdam this weekend. And I found out on Facebook, so I was like, please come and do the pub. So he is going to do an extra long Le Pub for us. We're going to have him in the bar for about 5.5 hours, talking about narrative-based medicine, how we can optimize our physiotherapeutic impact, and how we can create environments that are, you know, supporting improved outcomes for the people that we work with. So I think it's going to be awesome.
That sounds amazing. But is anyone going to make it to 5 hours? Is he going to be making any sense by 5 hours of drinking in?
So yeah, we do have to be really clear with this one. Like, there is not it's like maybe 1 or 2 beers. It's mostly an educate, like, but I mean, it's not a party. It really is just, you know, people sat down talking about science with a beer. It's not, it's not, it's just a really nice environment. But
well, it sounds amazing, and I would love to come over to Amsterdam and join you, but I'm struggle anyway to get to the London ones. So but yeah, if anyone is in Amsterdam and or thinking about heading over, because there's quite a few conferences coming up, then do check out Le Pub, and keep aware of Le Pub, because you guys are going to do some stuff possibly around this conference time maybe as well.
Yeah, well, we're not really sure, but we're in the process of thinking, okay, how can we do something, you know, because, you know, we've got IASP is coming to Amsterdam, which is great. So the people that come with IASP are like, you know, legends. So how can we sort of, you know, do something around that time that is, you know, cool and fun, but also means that some of this information is accessible to everybody. Like, you know, not everybody can go to a conference, but maybe they can come to the pub and have a beer and talk to somebody about something that might change their practice in a way they never thought would. And that's really the idea about Le Pub Scientifique, is it, you know, you just come and see what you think is useful and what you think is helpful. And that's the idea. We've got some other really cool things happening next year. So we also have Morten Huig, who's coming from Denmark to do a 2-day course, and sort of like looking at how do we take the pain science that we've all been learning, because I mean, the one thing we know is that clinicians are learning some of this stuff. You know, they're really trying, you know, the courses are filling up. People want to know how to understand the new science of pain, but then how do you take it to the next level, and what does it look like in the clinic, and how do you apply it in the clinic, and what does it mean to the way you use your physiotherapeutic tools that you've had forever. So that's one of the other things that we're doing. So yeah,
I think that's January, isn't it? Did you say?
Yeah.
I wish I could make it. I think I'm on holiday. But that sounds amazing. Well, I can't thank you enough for sharing your brain and your time. And I know you're really busy, so thank you so much for coming and talking a little bit about how we could use ACT with patients and what that might look like. Everyone, you need to follow Laura Rathbone. It's at Laura_Rathbone or at Laura Rathbone on Twitter.
It's Laura Rathbone.
And on Facebook and stuff like that. And have a look at Le Pub. And I'm sure we'll be talking again soon, hopefully in Amsterdam with a pint would be lovely.
That would be nice. And, you know, thanks very much for setting this up and for doing it. It's been great to be able to sort of like give away, like just talk about this stuff, which I could talk about all day.
And I think we will talk again about it at length. So yeah, thank you very much. And goodbye. Bye.
Okay.